to the Business and County Public Hospital District Number 2 Board of Commissioners meeting. And the first order of business is our patient story with our Chief Nursing Officer, Tina Toner. Tina?
Hi, welcome. Good afternoon. Alyssa, we can go ahead and start on that on the next slide. Thank you. So this is, I'm excited to share this story with you, and it's a little bit different than the type of stories that I share, but several months ago, we had a question brought to us from a bariatric patient about our capabilities for caring for them if the need would arise. And it was about the same time that we had just installed our new CT scanner, and that scanner has a higher weight limit of which is now I think 650 pounds. So we knew that we would have the capability of having potentially some more definitive information for our patients, and therefore could potentially keep more of our bariatric patients than we had previously. So that really inspired us to take a look at our process, and I will tell you that engaging in this work has really clarified our goals in terms of providing safe, appropriate, and compassionate care for this patient population. It's united our entire team, and I think really empowered us to rally behind admitting and caring for what can sometimes be a complex patient. We've expanded our ability to care for this patient by breaking down barriers between departments and improving communication. And we have, previously our staff felt a little bit underprepared to care for patients that had obesity or were patients of size, and we were lacking some of the right supplies. We needed better clarity on important information like weight limits for equipment and the safest methods to use in handling our patients. And additionally, the staff really needed to know and feel safe that they wouldn't be injured in providing patient care. A big thank you before we get started here to Mitzi Hazard, our Director of Rehab, who really took the lead on this work. And she worked closely with a very collaborative, multidisciplinary team, but key members of that team, Dr. Pratt, our hospice representative, Lindsay Burr, our house supervisor, and Kara Ely, our lead ACU, ICURN, were all integral in this work. So next slide, I'm just going to talk a little bit about what we've accomplished so far. As I already mentioned, there is just this kind of collaborative, empowered team looking at what we can do. And one of the pieces we're the most proud of is just this awareness and conversation about how we include the entire care team. And we do at this time, if we're admitting a patient that is a bariatric patient, we will pull together a pre-admission huddle, and we will make sure that our rehab, nursing, hospitalist, and ED provider are part of that huddle. And we will make sure that we can meet the needs of the patient, and as well that we have the right resources in place, the right equipment, and looking at just the specific patient needs that are present in that admission and need to be considered. We instituted huddles with our rehab staff upon admission to determine the needs related to the safe patient handling. And so at this time, rehab will place a placard on a whiteboard to alert nursing staff as to what level of assistance is needed for safe patient handling. And we also are really focusing on using assistive devices whenever possible. So things like our patient lifts, so that we can prevent injury from our staff as well. This collaboration with rehab has really been beneficial in our inpatient unit. We have, the team really comes together to troubleshoot movement and positioning and equipment needs and the selection of the right lift for the patient. And we have a greater emphasis on training and education around patient mobility and really on staff safety. And we've started some pop-up education opportunities that they include spontaneous fall drills with a focus on determining which pieces of equipment are the most important. So just a bit of collaboration there. Kara Ely and Maria Van Ness, two of our nurses from the ACU and ICU, they reviewed all of the equipment that we used for patients, and some of that equipment that it can be more appropriate for a bariatric patient. So things like we have our IV catheters. There are a longer catheter that's more appropriate for a patient of size. And so they have created a bariatric kit so that supplies can just be ready when we need them, so that we have them ready for the patient. And we also just took a look at all of the regulatory guidance and our policies to make sure that we were offering everything that we needed to, and that we didn't have any confusion between different policies and different departments. This next slide here, if you, Alyssa, is just a picture of an example of our bariatric bed that we have. And it's kind of hard to see in the picture, but it's wider, it's larger, and we also designated a room that preferentially, when it's available, we will try to use room 316 because it has a heavy duty lift in the ceiling. It's a larger room, and it just works really well when we have larger pieces of equipment and the larger bed in that room. The next slide, we are still working on many things. Dr. Pratt and our house supervisor, Lindsay, are working on a more specific algorithm for our patient huddle that I mentioned, and being able to work through and make sure that we don't miss anything as we are talking through that admission, make sure that we have all the resources that we need. We have put together a list of all of our hospital equipment weight limits, but we are continuing that work, and we're looking at other areas such as the clinics and waiting rooms in the lobby, and just kind of adding to that list. We've also begun collaborating with home health and looking at options for how we can help with patients that are homebound and in the home setting. And then we are continuing to look at what kind of other equipment is out there that can help both to minimize risks and ensure safety for our patient and our staff, and looking at how we can plan for those expenses in the future. And some of the equipment, there's just a lot of assistive equipment that would be helpful: motorized wheelchairs, slings to use during wound care that help a patient be more comfortable, and beds and mattresses with higher weight limits and that sort of thing. So really just wanted to share this with you. There's a lot of great work happening. I'm really proud of our team. And again, just a big shout out to Mitzi, Dr. Pratt, Lindsay, and Kara, and the entire team for working on this. I just think it's work that really translates to better care for our patients and safer care for our staff. And very proud to share the story with you.
Thank you.
Thank you so much, Tina, for addressing the unique needs of all of our patient populations. It's so important, and thank you for that good work. Any other comments? Bruce?
Yeah, thanks, Tina. I have to tell you, this is on me now, because it took me a couple minutes to catch up, because when you're talking about bariatric patients, I was thinking of bariatric wound care or hyperbariatric, so because my wife had some, or she was going to have some, it was bariatric treatment is what they called it. So
note to self, I will include a definition early next time.
Okay. Any other comments?
I was going to say well done, because particularly from my previous career point of view is that back in the day when we as nurses used to huddle together, we were talking about being used as human forklifts. And now I think in every patient room we have the assistive devices, and it's so much better for our staff, and so much healthier for our staff and also for the patient. So thank you.
Case?
Yeah, I think this taps into what Mike was talking about earlier, which is that for a small hospital like ours, hospital district, it's extremely costly, both staff-wise and financially, to be able to provide everything that our community needs. I mean, if we had, many patients who needed the service you just described, then it would become more, quote, cost effective for us to invest in that. But since we don't, we have to do it anyway because it's the right thing to do. And so it's just one more example of how we go the extra mile in spite of the strain that it puts on staff and our finances.
Okay. All right, anyone else? Okay, thank you, Tina, again. And we will move on now for approval of the May 26th regular session minutes. Is there a motion to approve?
So move.
Second.
Anybody? Okay, moved and second. Is there discussion? All in favor of approving the minutes as written, say aye.
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 Aye. Chair votes aye, so approved as unanimous. We now move to our required approvals. Is there anything that anyone would like to take out of that and discuss separately? If not, then maybe I have a motion to approve, please.
So move.
Second.
All right, moved and seconded. Is there discussion? All in favor say aye.
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 Matt? Is that an aye for you, Matt? Okay, and chair votes aye, so unanimous approval. So now we're on to our quality report by Brandy Manuel, and this is the annual critical access hospital report. So we look forward to seeing this, and Brandy, take it away. Thank you.
Thank you, Commissioner Bueller. And in full self-disclosure, I did not stick to my 6-slide limit this time. So I will talk quickly, but please do stop me if you have any questions as we go through it. Alyssa, next slide, please. Okay, so as we do with our all of our critical access reports, we'll be doing kind of an overview of 2020. We will look at volume and utilization of services. We'll talk about how we know sort of we're maintaining the high level of quality that we hope to provide. We'll go over policies and procedures. We'll look at some patient safety and quality work that has been going on, and then we'll talk a little bit about more department specific work. Next slide. And this is very, very small, so I apologize in advance, but it will be in your slide deck for you to take a closer look at. And this really just is a copy of the conditions of participation that outline the elements of that need to be included in the report. And a note that there are a couple places where we have a more general overview, because to list out sort of all of the pieces to it would be very, very small. So we can provide those in a separate packet if you're interested in looking at those. But overall, these are the required elements. Next slide. All right, so it would be just very disappointing to all of us if I didn't start off by saying 2020 was an unusual year. It was the year of COVID, and it certainly had an impact on the operations of Jefferson Healthcare. So I think it's interesting to just kind of pause every once in a while and think about where we started and where we are now. We actually started our incident command journey on February 4th, and that was really a preparation phase. That was the recognition that something was going on in the world that potentially could reach us here in Washington State. So we thought, you know, we're going to go ahead and stand up our incident command structure. We're going to just test the system and see how we do and see how we function as an incident command team. We're going to make sure that we feel comfortable that our staff knows how to use PPE and knows where to get it. And ultimately, we want to have a plan to minimize exposure to this potentially infectious disease. And we also want to think about, you know, if the time comes, how will we communicate? And so we started meeting about once a week with the public health department in just kind of a preparation phase. And within a few weeks, Dr. Mattern visited my office and said, hey, the theoretical just became real. We have residents from Jefferson County who have been associated with the outbreak in King County. And so we made a transition, and we kind of changed from this preparation phase to really a response and mitigation phase. And so we transitioned the team. We began meeting daily, sometimes more than one time daily, sometimes all day. And we changed our objectives just a little bit. So we shifted to really these 4 principles, which are kind of what we're still operating under today. We wanted to make sure that we were keeping our employees safe first and foremost. We wanted to stay connected through effective, transparent communication. We wanted to make sure we were building the right delivery system. And of course, we wanted to safeguard our future. And
I'm sorry.
yes,
Could I
go
ask
ahead.
a quick question, Brandy and Jill? Would you like us to hold our questions till the end, or how would you like to do this?
Brandy, that's up to you.
Feel free. If you've got questions, it's probably just as easy to go ahead and ask them as we go.
Okay, why don't you finish? But before you leave this slide, could I ask a question, please?
Absolutely. So one of the things in kind of doing a year in review and looking back, I wanted to ask our leaders, how did they perceive their team being impacted by COVID-19? So what you see on the left-hand side was just kind of the responses that we got from our leaders. And really you can see by and large, the biggest impact was to staffing, and followed up by supporting the infrastructure for COVID. So it was really not so much the direct patient care, but it was building this incredible infrastructure to provide the care. Commissioner Kolf?
Yeah, these impacts, you have discontinued service. Is this temporarily discontinued service in order to be able to deal with COVID-19?
Great question. It was discontinued service. Yes, it was temporary. And most of those were in response to the governor's proclamation that elective services be paused.
Great.
So, yeah, very much looking forward to. In fact, one of the things you'll see later is our leaders are very anxious to resume all of the things to the community. Next slide, please. So thinking about sort of the goals that we had, and then what did that translate into? We can see some of the key milestones here and some of the ways that we expanded services to be able to provide that infrastructure. So again, kind of through the lens of looking back now more than a year later, it's been over a year since our nurse hotline opened up, and as of last week, that hotline had received over 220,000 phone calls. Looking at the respiratory evaluation station / COVID clinic is what some referred to it as. We have over 4,000 visits to that clinic. And then the vaccine clinic has given nearly 26,000 vaccines with almost 13,000 completed series with less than 1% wastage, which is incredible. Looking at the drive-through testing, they have done over 12,000 COVID tests through the drive-through. And then in other areas, just made plans and created plexiglass and made sure that we had as safe an environment as we could. We created separate areas for symptomatic patients versus patients who were there for other reasons, and did a lot of work on surge planning. So did a couple of tabletop exercises, one kind of looking at the acute care phase of things, and then one looking at the post-acute care phase and making sure that our surge plans were as buttoned up as they could be. And then just really relying a lot on technology, as you see here today on our meeting, to minimize the exposure to each other, but also help connect patients with services that they were not able to get in person. So we were giving them the directive to not come in for care, but we still needed to make sure that they had access to care. So how do we do that? We did it largely through technology, and really it was about the time span of a week where I think in incident command we said, you know, we really need to look at telehealth, and we actually had it turned on and available for our patients. So again, just a real success story and a commitment of all of the teams to really adapt to this unusual environment. Next slide, please. All right, so next slide. Okay, so here are the overall utilization of services. You can see kind of year over year how we've done, and of course 2020 is the year in green because it was just a very unusual year. So overall, not surprising, we told patients not to come, and Port Townsend responded in a very compliant way. And so you see that the visits decrease in almost every area. One area where we did not decrease, we actually saw an uptick, was in lab, which makes sense as we had all those COVID tests to work through. And then we also had a bit of an uptick in specialty clinic visits, but that was after kind of a little bit of a downturn the year before. So overall visits were down. Next slide, please. And taking a look at our acute care census. So what you have here on the left-hand side are those patients who were admitted as inpatients. Again, remembering that we are, as a critical access hospital, limited by our 25-bed inpatient count. So this looks at the average daily census by month. So the blue line there with the kind of the number at the top represents the average daily census at midnight. And then the orange dots there represent the total number of patient days for that same time frame. So for the entire year, we had an average daily census of about 14.7. And then over on the other sort of graphic there, it shows us the census by unit. So again, kind of how many patients were in-house for each one of those units at midnight during the selected time frame. And then the total number of patient days for the entire year. Next slide. And this just slices kind of the same data a little bit differently. So not only are we bound by that 25-bed limit, but we're also bound by a 96-hour length of stay. So as a critical access hospital, we are required to maintain an average length of stay of 96 hours or less. And so one way we track this is by looking at our discharges per unit per month and looking at that overall average length of stay and making sure that we are staying well within that 96-hour time frame. And so on the bottom side, you can see the average length of stay compared to the overall admission. So it's that sort of orange dot, again, being kind of consistent. And you can see there was 1 month where we reached right up to that 96-hour, but otherwise we were well within that range. Next slide. And this just pulls out home health and hospice visits. So you can see this wasn't represented in the other slide, and this just takes a look at where we saw patients, most of them being in home health who expanded their ability to provide services for patients last year. And then the blue kind of color on the bottom represents hospice, and the dark blue line represents the number of individual unique patients who had a visit during that time frame. And then over to the right, we've got our payer mix, no real changes. This has been pretty consistent the last few years, continuing to see most of our payer mix coming from Medicare, and then followed by commercial insurance and Medicaid HMO. Next slide, please. So the emergency department was interesting. We showed earlier that that number decreased for 2020, and here you can really see when it happened. So looking at March, you see this really pretty drastic drop down. And what you're seeing here in the blue line represents sort of all of the visits who ended up being discharged home. And then the yellow or the orange or gold, whatever color you want to call that, up at the top represents the patients who ended up being admitted through the emergency department. So kind of looking at that as a rate. But you really do see this, this dip down as the governor proclamation came out and really said, folks, stay home if you can stay home. And then over to the right, just kind of continuing to look and see, we admitted nearly 8% of our patients who presented to the emergency department. We transferred 5.2%, which is really consistent. Interestingly, I took a look at 2019 and we transferred, I think, 552. So very close. We kept a few for observation, very few left against medical advice, and very few also left without being seen. For the sake of comparison, I made a note, and we were about twice this rate for left without being seen in 2019. So just a great job by the team in the emergency department and really making sure we kept that number down and working on it. So great progress there. And then up at the top hand corner, it's a little confusing to kind of look at it, but really what this shows, the bar represents kind of the number of visits by acuity level. So immediate, emergent, urgent, less urgent, and on down. And the gold dot represents those patients who were admitted. So what we see in looking at this data is really that the patients who are being admitted really are the sickest of the sick, which is what you would expect from a utilization of services perspective. Next slide, please. And in diving into why patients were transferred out, no real change here either. Our number one sort of transfer out was to cardiology, followed by psychiatry and neurology as kind of our top three. Although neurology was tied with gastrointestinal services, and most of the reasons that patients were transferred were because they required services that we do not provide here. Next slide, please. All right, before I go on, any questions about utilization of services? Commissioner Koff?
So yeah, I was very interested in that last slide in terms of the transfer, the reasons for transfer out. And could you also mention the number of patients who had COVID-19 who were transferred out? And was that for cardiac reasons, pulmonary reasons?
I could pull that data out. It's separate from this data set. So we had a few patients who were transferred out with COVID, and by a few, I want to say probably 3 or 4
Right.
In 2020. But I can certainly get those numbers for you.
No, that's fine. Yes, I do recall that the number was very, very small, so it wouldn't make a significant difference on a chart like this.
But happy to get it if it's of interest to the board. All right, next slide. Next slide. Okay, so just a reminder of the areas that we sort of monitor on a regular basis, and most of these are on the inpatient side, though we do a fair amount of chart review and monitoring on the outpatient side as well. And we certainly exceeded our requirement to review 10% or more of those patients who are admitted to the hospital. Next slide, please. All right, now this is kind of the fun stuff. And, you know, in thinking about 2020 as the year of COVID, I thought, oh gosh, I don't think we did anything but COVID. I can't remember. It just all feels like all COVID all the time. And so I reached out to our leaders and I kind of surveyed the landscape, and I was really, I don't know why, but I was surprised by what I found. So next slide, we'll take a look at that. So again, policies and procedures, we are required through DNB and CMS to do an annual review of all of our active policies, procedures, and contracts. In 2020, we had 188 active contracts with outside agencies. We retired 113 of those. And when we do our annual review, we do a review of services. We look at the deliverables. We identify whether what we're paying is what we agreed to pay, and whether there's any sort of follow-up discussions we need to be having with those vendors. And in 2020, we had 1,851 total active policies and procedures. Yes, you read that right. We created 127 new policies and procedures and retired 66. We do require an annual review, again, of the policies, and we were at 98.06% compliance. Our goal is, well, we'd always love to be at 100%, but our target is 95% or greater. So folks were doing a good job of keeping up with their policies and procedures. Next slide, please. All right, here's where it gets kind of fun. So thinking about expanded services in 2020, I asked our leaders to just share what were the things that they added to their department, really expecting it all to be COVID, because that was where my brain was at, and it was not. So you'll see here that most of them, that was kind of where most were. But in addition to COVID, there were extended hours in many locations. We implemented some new specialties. We actually put into place new equipment. So kind of looking at this, you'll see the dental clinic isolation bays. That was a way that we were resuming services after the governor's proclamation. So trying to do that as safely as possible for our patients and for our staff, our facilities team created dental clinic isolation bays. So that beautiful open dental clinic that we had turned out to not be so great in blocking aerosolizing things that kind of can be transmitted in the air. So they did a really great job of helping us safely resume services there. Implemented core unit for total knee replacement surgery. And so that's a robotic assisted surgery, which is pretty exciting. Reconstruction following cancer surgery. We brought our emergency department providers in-house after being contracted for many years. Expanded women's health services. We expanded our services and access to services in home health and hospice, which was great. Implemented hospice televisits with the medical director to give greater access to our patients to the medical director. We implemented new cancer treatments. We implemented a new CT scanner, as Tina mentioned earlier, with an increased weight limit, which was great, which also, this one really excited me, had a power backup. So hopefully gone are the days when CT has a power bump and goes down for some period of time. Also offered, and we talked about this earlier, primary and specialty care via telehealth. We added methylcholine testing to rule out asthma and respiratory therapy, and again, expanded hours in oncology and infusion clinic. Next slide, please. And since so many of our leaders responded and said that they had been part of working on the infrastructure, both related to COVID and just generally speaking, I wanted to take a look and see really what did that mean. And you know, when you stand back and think about it, it really is amazing in light of all that was going on in 2020, how much work was done to really support the care that was being given. So on the left-hand side, you can see all the sort of COVID-related infrastructure. And then on the right-hand side, some pretty big things. So there was a new HVAC system with humidity control improvements in surgery and UV light air purification. Our facilities team remodeled the Mohs area in the dermatology clinic. We digitized medical staff appointments and reappointments. We offered simulation training for our clinical staff. We implemented an Infor upgrade, which was a big lift. We brought on new providers. We had our standard Epic upgrade. We expanded the use of barcode readers for barcode medication administration, particularly in our clinics. We increased the use of point of care ultrasound and purchased additional units. And Dr. Erickson has been instrumental in really training additional providers. And Dr. Eyrich has led our point of care ultrasound, or POCUS, quality committee, and it's growing by leaps and bounds. We also made investments in our data infrastructure and developed new workflows in employee health. And I want to just emphasize the work in the data infrastructure has been significant. I think that our data team was one of the unsung heroes through COVID. And really every decision that we made, there was data to support those decisions. And even when it seemed like the data was not possible, not knowable, not gettable, they found a way to pull a rabbit out of the hat and provide us with that data so that we could make really informed decisions. So just a note of appreciation to that team. Commissioner Koff?
If I could add to that appreciation, I've also seen the data people, in particular Adam York, at work with the Health Equity Committee and the amazing work that they're doing so that our data can become even more useful as we try to develop a more equitable and just healthcare system.
Yeah, thank you. Next slide, please. And a few updates to the medical staff. So in 2020, we added 52 providers to our team, including telemedicine. We had 9 resignations, 24 telemedicine resignations, which is pretty typical. They kind of flow through on a regular basis. We get new ones and some of the existing ones leave. And we ended the year with 41 allied health providers and a total of 287 providers, including telemedicine on our staff, on our medical staff. It's kind of amazing to think about that number. When I started, I don't even think we had 200. And so to see it reach this place feels big. We reviewed 35 medical staff policies, created a couple of new ones, and revised 9. And then we also have been actively reviewing our delineation of privileges, or otherwise known as our core privilege documents, which are the documents that are used when we're credentialing providers that kind of outline what their privileges are. Next slide. And taking a look at who those folks are that we welcome to our team, you can see that we kind of everywhere from primary care to specialty care, emergency medicine, and then lots of teleneurology team members added to the list. Next slide. So one of the things that we look at when we kind of pull all of this together is our quality and process improvement work that occurred over 2020. And I wanted to understand, we have a lot of new leaders on our teams. And so I also just asked, how could we better support your process improvement work kind of moving forward? And so what you see on the left-hand side is just kind of their responses. And really, the most popular answer was, could you create dedicated time? Could we create dedicated time? So that's something as we build sort of our toolbox and as we rebuild our process improvement programs, making sure that we're including dedicated time to work on those projects is something we'll be acutely interested in. Also, the next one is, or the next most popular was, I don't need any help. My projects were awesome, which is great. We want to see more of that. And then kind of next in line, we want some more tools and training. So those are some things that we'll also work on. But by and large, not surprisingly, it's just that dedicated time or the one-on-one time with their leaders to kind of go through projects and prioritize. So even though it seems like all we focused on in 2020 was COVID, there actually was a lot of other stuff happening. And so I won't read them all to you, but they're kind of over on the right-hand side. And, everything from really shortening the time that a provider applies for privileges to the time that they are appointed to the medical staff, that got shorter. To reducing blood culture contamination. I think something that didn't make the list but is definitely list worthy is the work that Tina mentioned earlier with the bariatric patient care team. Also, Mitzi Hazard has done a great job with our fall prevention program. That wasn't on this list, but it definitely deserves some high praise and lots of work up on the floor with our acute care patients, but also looking at a kind of a community perspective and how we can continue to work to prevent falls and falls with injury in our community. Next slide, please. And then just a moment of appreciation for our infection prevention program. Thinking about the goals and the role of this program has been pretty, I guess it's been front and center this year. But you see in 2020, our goals as a program were to make application for the D&V certification, to implement a program for endoscope testing and reprocessing, to increase our hand hygiene compliance. And interestingly, before we knew there was going to be a pandemic, we thought based on our hazards vulnerability assessment that that was something that we should be prepared for. So that actually made the list of things to focus on. And kind of moving fast forward, we achieved the certification. Laura and Bill and Tim Oda and Andy in our surgery clinic have really come together and done just a beautiful job with our endoscope processing policies, procedures, training, feedback. Just really have designed a great program. Laura worked directly with our leaders to really re-engage them in our hand hygiene surveillance and coaching, and have seen excellent compliance there. And I've already talked enough about COVID, so I won't say much more about how that fared. But overall, met the goals of the program for 2020. Next slide, please. And then again, just in the vein of performance improvement, I think one of the most interesting projects and probably the most important was the work around PPE. So kind of if everyone takes a step back and remembers, gets in their time machine and goes back a year, we didn't know how much PPE we had on hand necessarily. We knew in areas, but as a whole, we didn't know how much there was. We didn't know how much we were using. We thought we generally knew that people were using it appropriately and that they knew how to use it, but there were real gaps in just understanding what did we have as a program. And so this was an evolving process, but it was such an important one through COVID. And I think even after, we developed the PPE, what was called the PPE Executive Council, but really that was made up of several groups. And one of the most impactful you have heard of and awarded the employee or the team of the quarter, and that was our PPE Employee Council. And I think that that was such an important group in really helping us understand where were the trouble spots. You know, we got to hear Cassie talk earlier about what it's like to watch those care team members don and doff their PPE or wear that PPE all day long when it's hot and your lens is fogging up and you're getting a headache because you've been wearing the goggles all day long. And I think that's something that's easy for us to forget who are not at the bedside anymore. And so this team was just so critical in really helping us to remember what that's like and hear directly from those who are providing the care what their experience was. And it was encouraged for them to come to us, to come to the team and to say, hey, these gowns, they don't cut it. This is not going to work. And Kelly did such a great job of going out and finding different resources to try and better meet the need. So through this, I think that it's an example of how really powerful systems can come together. And as a result, we, I think, have developed just this really great best practice of getting the feedback directly from our team and having that really be the guide in how we move forward with all things PPE. So that'll be something that we look to replicate in the years ahead in other projects, I think. Next slide. So one of the things that I asked of our leaders was whether they could give me some feedback about anything else that they wanted to highlight. And so what you see is this word cloud up at the top right-hand side. And those were the words that were most often mentioned when I asked for their feedback. So you see front and center. I didn't design it this way, but patients was sort of the number one thing, followed by community. Those were the things that were really emphasized by our leaders. And you see kind of just a handful of the comments. I wanted to include all of them and I just didn't have the space. But really it was, the words that popped out were, my team. Dedication, community involvement, being so proud to be here for the community. And so I think it's worth a moment of sort of recognizing the sacrifices that those teams made. Next slide. All right. And we did not use COVID as a moment to stop giving really great care. So you see here are some of the recognitions and awards that were received in 2020. Next slide. And that's it. This was a comment that I got from one of our leaders that was too good to not include, but I think sums it up very nicely.
Well, Brandy, thank you. It is absolutely amazing that your team, our team, could not only improve and expand and maintain all of our excellent capabilities and services in the throes of a worldwide pandemic that just is amazing to me. Thank you to every single person involved, everyone on the Jefferson Healthcare team. It's just warms my heart. Any comments, questions, Brandy?
Well, I've just endorsed what you said, Jill. It's just absolutely amazing. And every member of staff should be able to pat themselves on the back, and leadership team as well. I mean, it's just incredible. And one other comment, when I came here in 1982, as a member of nursing staff, we had 10 providers. One urologist, one surgeon, and the rest were one radiologist, and the rest were primary care. So way to go in 39 years. Look where we've come.
Okay, great comment, Laurie.
Yeah, the other thing I'd like to add is, well, first of all, to reiterate what Mari and Jill said, but I'm curious, this goes to CMS. I wonder if it should go elsewhere. I mean, there's just so much important information in it. And it reminds me a little bit of Mike's presentation when we did the focus groups or the forums last week. You know, here you have all of this incredible information that most people have no clue about. And I just hate to just see it go to CMS and not anywhere else. So if anybody has any good ideas as to how we can get some of this information out to other people who really should know about it, we should just figure it out. But thank you.
I second that. Anybody else? Thank you, Brandy, again for a great report.
Thank you.
Great job. So we will move on now to our financial report with Tyler Freeman, our Chief Financial Officer. Tyler, welcome.
Hey, good afternoon.
Good afternoon.
If we want to go to the next slide. This has quite a bit more red on it that I was hoping for my second presentation, but when we move on to the income statement, we can see that it's not as bad as you may expect just looking at the statistics on their own. So, and one other thing that I want to point out is when we look at these and we see the May 2021 actual to budget and the year to date of 2021, there's a lot of red, but when we look at the comparison to May 2020, we are doing better year to date in every statistical category that we track than we were doing in May of 2020.
Excuse me, Tyler. I'm not seeing the slide, and I don't think
I'm not either quite yet. I agree.
Oh, I see it on my end, so
I can see it.
okay.
I can see it.
Being discriminated against.
Mari, it's you and me again.
Uh-oh, something wrong there.
You're out in the country.
So
Mari's not. She's in the hospital.
There we go. Now I got it.
Perfect. Thank you.
All right. Okay, so now you can see all the red and green I've been talking about. But when we compare May 2021 year to date versus May 2020, doing better in every category that we track, and that's with 4 additional FTEs. When we look at FTEs, we're a decent chunk below our budget, and we've probably been, because as we looked at the beginning of the year, these stats have looked even worse than they do now. So there's probably some level of overstaffing that was happening in the beginning of the year, overstaffing in the beginning of the year, and now we're starting to maybe transition into a period of understaffing when we do see these ramp up and we see that we're below budget. So there is a little bit of that whiplash effect, and staffing is definitely something that we have our pulse on and have been tracking very intently. Going through some of the other metrics, so ICU, ACU, and total patient days are below budget in May, and that was the case in April as well. One positive thing to note is as of June 19th, these are 5% above budget. So we are starting to see them trend in a more positive direction. We are seeing beds be a little bit more filled up. Some other things to note too are some of the areas that are red on the stats report don't have a corresponding negative when I actually look at the revenue side of things. And so surgery cases is one of those, 6% below budget, but actually 23% above budget for surgery minutes. And revenue is coming in strong in surgery. Same with lab at 3% below, diagnostic imaging at right at budget, and pharmacy meds being 20% below. All of those categories have been, along with surgery, some of the higher revenue generating categories so far this year. So they've been the ones that have really been carrying us from a revenue perspective. And so the statistics just aren't quite in alignment with how the revenue has came in. And pharmacy meds, wanted to point out that we talked about this last month as well, and it was lower than budget. And after going back and looking at that number, we found that there were some stats that were not being tracked. So we did update that number. After updating it, it led to an increase in the total amount of meds dispensed, but still less than budget. Budget has been around 24,000, and we've been hovering around the 19,000 rate for meds dispensed.
I have a question, Tyler.
Yep, go ahead.
I noticed that the ICU, ACU, and patient days was also below budgeted in 2020 compared to 2021. And I'm wondering if there's something that happens in May that typically causes that to appear that way. I mean, it's obviously not as great, but it is significant.
And that comparison, so the negative 2% that you see for May is actually saying that ICU patient days for May 2021 were lower than they were in May 2020 by 2%. So that's.
Oh, I see. Okay, so that is a comparison between the two Mays. It says nothing about whether May 2020, how it compared to its budget.
And I think we can probably go with the assumption that everything in 2020 didn't hit its budget.
Yeah. Okay, thank you.
Yeah. So moving along, one thing to note about diagnostic imaging is mammograms were 10% above budget and also 50% above where they were in May 2020. So that is a really encouraging sign that some of those preventative screenings are really coming back up full force. ER census is another one that was below budget for May, but is trending positively in June. So June 2019 or June 19th, we can see that that is about right at budget, and so we're hopeful that we're starting to move in the right direction. Rural health clinic, 12% below budget, and that was kind of across the board. There's no specific clinic that I can point to that that was kind of carrying the brunt of the below budget. It was just a little bit of a smattering of all of them. And specialty clinics, the two that popped out to me were the sleep clinic, are both below budget by a pretty significant amount, and they're also below the May 2020 run rate. And sleep, we talked about this last time, sleep is down FTE, so that could be one of the contributing factors to sleep is not having that full provider workforce. So any questions on the stats before I move over into the income statement? All right, next slide. So as I said, the income statement is not exactly where we want it to be, but it's not as bad as you would expect based on how the statistics looked on the last page. So overall, we only missed our gross patient revenue line by 1%. And that was really driven by the inpatient side of things, inpatient was 32% below budget, whereas outpatient was 6% above budget. And then the other interesting thing here is you would think that with a gross patient service revenue that was about at budget at 139,000 off, and then going down to the operating expenses and seeing that we were able to manage our expenses, 288,000 in the positive, we wouldn't expect to be in as big of a loss position as where we are. But that's really due to the revenue adjustments. And the revenue adjustments is a line that we've been trying to really get our arms around and figure out what is rolling through the adjustments, and do we have them properly classified, and are we sure that we have the right estimates in there. Revenue adjustments are always an estimate because we're trying to guess how much we're going to get paid for the services that we performed. And there's a lot of contributing factors. There's rates with the payers, there's denials, is the patient responsibility going to be paid. So there's a lot going into that. One of the things that we did learn going through some work with Providence is that by not, and this is not to get into the philosophical discussion of sending folks to collections or not, but the traditional approach and the way that Providence has it built out for every single entity that is under their umbrella on their Community Connect and part of Providence is that the way to move somebody into the bad debt section is to send them to a collection agency. So there is actually not a single entity under that umbrella that's not sending folks to collections besides Jefferson Healthcare. And so because of that nuance, we have a little bit of a different process that hasn't been fully vetted yet. And so that's contributing to a little bit of lack of visibility, so to speak, with the revenue adjustments. And so we're working through that with Providence, seeing how we can make that change. But it was something that we discussed the last time we were with them. And really bad debt, it is traditionally when you are sent to collections, but bad debt just at the crux of it means that you have a patient account, the patient is unable to pay, and you are not going to be able to collect on that account. You don't necessarily have to send them to bad debt or to a collection agency for it to be bad debt. So that's something we are still working through. And as we mentioned last time, when we have DZA on site in July, we're hoping to have a little bit more visibility and more information to provide to you all. Other revenue line was up, and part of that is a $350,000 receivable that we had booked for the county. This is in regards to unreimbursed COVID testing expenditures that they are going to have a grant for us. So we have that posted. Other expenses, as I mentioned, we did a good job of managing expenses overall. We did have a few categories, purchase services in particular, that we were over budget. This was in regards to the break law attestation requirements that we had to have a third party come in and help us get set up with our Kronos timekeeping. And also the audit fees came through in May as well. And as we look at the board report, we can see those go through, and I have a little other information to provide on regarding those. So overall, $500,000 loss for May. May year to date is almost break even at a $27,000 loss, but we are about $3 million ahead of where we were in May of 2020. Yes. So it is, that does make sense. We expect to receive those funds in July. We did already book it as a receivable. So when we booked it as a receivable, the income came through on our income statement. And we did that because we've been in constant communication with the county, and we knew that these funds were going to be coming at some point. And so we booked them as a receivable as soon as we knew that they were going to be coming in short order. Any other questions on the income statement? Hearing none, we can move on to days cash on hand and AR. So this is pretty close to where we landed at last month. The 2-day drop in the days cash up at that top green line, that's our days cash with the Medicare advance payment, and we have started having recoupments on those. So far through May, there had been $800,000 recouped by Medicare. That means that we still have $17.2 million left to pay them, but that will slowly come out over the next 17 months. So the process for that is they will recoup 25% of our payback for 11 months, then 50% for 6. And then if we still have additional funds left over, we have to pay that within 30 days, or we will have a 4% interest rate on that loan. So we expect to see that number continue to trend down towards our other days cash on hand, which is the 109, which is the days cash without including that Medicare advance payment. All right, and then next slide. Can we move ahead to the next slide? There we go. At least I can see it. I don't know if anyone else can.
Yeah.
So, May board report, as I said, the $35,000 of audit fees from DZA have come in, and those are going to be DZA is going to have a little bit more expenditures this year because we have a financial statement audit. We're going to have the cost report, and those are 2 typical things that we have. But we also are required to do a single audit, and a single audit is required anytime you expend more than $750,000 in federal grant funds. And so our FEMA funding is going to count towards that. And so they will do expenditure testing on our FEMA funds. And next slide, which should be the last one. So June is, as I mentioned with a lot of the statistics, it's looking good in a lot of areas. ED and inpatient have started to move in alignment with our budget, which is making us pretty high above the expectation for gross revenue. And I think the slide popped down on my side, but it's 117% of budget is where we expect. And then cash collections have also been higher than our goal at 346,000 per day. And days in AR are still in a positive spot as well. So any question on the finances I can answer that we haven't already gotten to.
Okay, no questions? All right, thank you very much, Tyler, and good report. And we look forward to a good June. So thank you.
Thanks.
Thank you.
All right, we'll go on to Mike Glenn, our CEO, for the administrative report. Mike?
Right, thank you, Jill. Just to carry over on Tyler's presentation, included in my last month's board report was the letter from Kate Dean regarding county grant agreement for unreimbursed COVID-19 mass vaccination clinic costs, which spelled out their commitment for the $350,000 after May 17th. Next slide, please. This will probably be the last time I will present the big dot number of 25,000, almost 26,000 vaccinations. Next month, I will transition to a vaccination report that tracks vaccinations by clinics. We are now providing vaccinations in Express Clinic, emergency department, most, I think, all of the clinics in Port Townsend, and we're moving out to Ludlow and Quilcene. So I think it will be interesting and to show a monthly report on the number of vaccinations we are giving in each one of the clinics. This is the roll up, but going forward, I'll show that to you broken out. I think it's kind of interesting to see as we are attempting to make that less burdensome for our patients, where we are seeing the most action. But 26,000 shots, nearly almost a 50-50 breakdown first and second shots. Wastage has gone up a little bit, which we expected because of the new model of opening up vials for 1 shot, 2 shot, 3 shots, however we can get. Next slide, please. Volumes, we've talked a lot about volumes, so I'll just kind of skip over these quickly. The phone line and clinic visit volumes, after a couple of down weeks in mid-May, popped up again in early June, and the drive-through testing station continues to be busy, mostly for pre-op clearance purposes. Next slide, please. Primary care clinics, very busy, as are the specialty clinics. So it looks like we have been successful in convincing the community to seek care when they need to seek care, and that it's safe to do so. Next slide, please. These are cancer volumes, a little bit below target, and I think, as Tina has mentioned and Brandy has mentioned, surgical volumes for the last couple of weeks have been above target. Very, very busy team down in the OR. Next slide. And this is our emergency department and express clinic, and the volumes are coming back to 2019, end of 2019 levels. And again, the primary reason I'm interested in this is that that's some marker for our people feeling comfortable coming to the emergency department when they should be coming to the emergency department, and it looks like that is occurring. I think we ran about 7-8% below budget in May. In June, we are almost spot on target. So if that's a good estimate of community need of our ED, it appears people our patients and our community, they are now comfortable seeking care when necessary, and our ED team's doing a great job keeping up with kind of modulating census and very challenging patients. Next slide, please. I wanted to give you a quick advocacy update. There's a lot of issues that are sort of in the works and bouncing around. But the first, I'm not sure you are aware of this, but about every month we have a Jefferson Healthcare Advocacy meeting where Dunya runs it, and a couple of members of SLG, and more importantly, a couple of our providers are involved in the meetings. And we just keep abreast of what's going on in Olympia and what's going on in Washington, D.C. And we pick the minds of our providers to see how we can position some of the issues that we are interested in. But it's a way for us to sort of keep track, monitor, and prepare for what our advocacy issues and positions might be in the coming months. I think I may have mentioned at the last meeting that the Critical Access Hospital Modernization Act is a thing again. That Representative Kilmer believes strongly that the attempts to modify critical access hospitals of 2 years ago were probably short-sighted, because the motivation was and the trade-off was, if a critical access hospital shut down their inpatient beds, they would receive up to 110% of cost payment for their outpatient and emergency department services. And I know that has been an area of interest in Olympia with some legislatures, that they believe that the state of Washington is overbed inpatient-wise in many rural communities. But that was before COVID. And if you followed what happened in Republic, at the little hospital in Ferry County, where there was a super spreader event, and that little hospital that typically averages a couple of patients a day, they were completely full, taking care of very sick patients. And in addition, like us, they were the primary players in the COVID response effort in their community. So we are positioning, and as you may recall, CAMA is just an extension of the payment methodology that we currently enjoy as a critical access hospital, that it would allow for services like home health and hospice and ambulance and skilled nursing and behavioral health care to be included as critical access hospital eligible services. And what that means is that those services would be eligible for cost-based reimbursement, and that we could include them under our cost report, so that by offering them as a non-critical access hospital eligible service, we wouldn't be financially penalized. It's the issue with DBH a couple of years ago, where by virtue of slapping our name on their door, it would have penalized Jefferson Healthcare $500,000 a year because its cost report or overhead costs that we currently are allocating to critical access hospital eligible services on our cost report, and we could no longer allocate. So that basically what began our interest in pushing CAMA was that DBH decision, where it was terribly frustrating to have to make a decision that I think would have been better for the community based on this wacky, outdated critical access hospital law. Because 20 years ago, when critical access hospital law was originated, hospitals weren't in the substance abuse and the mental health care, the skilled nursing facility, home health, hospice. Those were business services that were provided by other entities. But today, in nearly every rural community, a critical access hospital is providing those services with financial penalty, or they are not, at the to the detriment of their community. So we're gonna continue to pound on that. Cassie mentioned the innovative payment for rural hospital committee that I am on. CAMA is one of the proposals that group is considering, and Dunya and I are cheerleading and the effort and trying to gain enthusiasm throughout the whole state so that critical access hospitals can better meet the needs of their community and not take a financial pounding by doing so. Rural Advocacy Days in Washington, D.C. The big effort was canceled by WSHA for safety reasons. There's some discussion about what we're referring to as mini rural advocacy days, where it wouldn't be the heavily scheduled half a day with AHA, half a day, preparing for the day on the Hill and some of the other activities, but just more independent, hospital-driven, issue-oriented, because there is some concern about not being in front of our congressional delegation when important issues like 340B and infrastructure funding are being discussed, and without a hospital voice in the room. So that's something that may come together. And then there's Rural Advocacy Days in Olympia that typically happens in January. That if it does, we will take part in as well, because I think that there's a lot of activity going on in Olympia, most of it well-intentioned, but it's always helpful for representatives from critical access hospitals to speak to our legislative delegation in a way that explains all the implications of a particular issue. Next slide, please. And then I just wanted to just give a shout out to Chris Harris and Jackie Levin for great work with our Juneteenth celebration. Wow, that's really cool. And Pride Day. If you came by the hospital all of last week, we had these educational boards explaining the history of Juneteenth. We had Black American dietary dishes presented each day to reinforce the cultural issues. And on Wednesday we celebrated Pride Day with flyers, information, and cupcakes, of course. But it was a great event, a great week, and a start. Chris is going to continue to look for these educational opportunities and reaffirm our commitment to this work by making it very visible. So great job to Chris and Jackie. Next slide, please. And I should also say, Dunya is Chris's partner, and Tina Herschelman was awesome in helping put together the boards. Chris was responsible for the content, but Tina helped with the design. And I think lastly, just an update on our strategic plan process map that we sort of created at the beginning of the year. We're through June, the 2 community outreach meetings, and now SLG is going to do more work to try to get a little bit further with the language of the initiatives and strategies supporting the goals, and then come back to the board August with an updated strategic plan presentation with at least 1, maybe 2 more bounces. And in that time, I'm going to get in front of the medical staff and seek their counsel. And SLG has a couple of retreats scheduled to drill down on the work too. So I think that's it. That concludes my presentation. I figured you got enough of me last week, so I kept it a little short today.
Thank you, Mike. Are there any questions from the board? Well, I have one. Do we have, and maybe this is better for Dr. Mattern, but do we know how many people in our community are not yet vaccinated?
I don't know if Joe knows the answer to that, but this is a great segue to Dr. Matter. So
Yeah,
take it away.
that's good. I can give you I can probably give you at least a rough estimate. I think just to kind of start off, that's probably good is kind of talk about COVID, and my notes here of sort of what I was going to talk to you all about was, when we talk about COVID was we're now in the new reality. And the new reality is the difference of the COVID experience between the vaccinated and the unvaccinated, really. And in Jefferson County, fortunate to be still one of the most highly immunized counties, where we're looking at around 30% unvaccinated, around 70% vaccinated. Now, those numbers, if you just include 16 and up, or 18 and up, or 12 and up, it kind of varies a little bit, but I think from a standpoint of kind of general ballpark numbers, I think 70% is probably a good place to be thinking, which, if you think is, kind of the national targets, is where we're at. And the new reality of what we're seeing with COVID, some of you might have seen, there was an article about a government office in Florida. I think it was Bradenton, Florida, and this hit the kind of national news, kind of byline, and got picked up, which was that there was an office, I think it was an IT office, and in the office, 5 or 6 people came down with COVID. 2 of the workers died. I think a couple other seriously sick. In the cohort in the office, the one person in the office who apparently did not get through numbers of hospitalizations, over a year of COVID, we hospitalized, maybe 16 people, and then in the last 5-6 weeks, we seem to have at least one COVID patient in the hospital, kind of at all times, and that's unusual. And it's happening among the people who are being admitted are unvaccinated. And there's interesting dynamics, and I don't mean interesting in a good way, but because there's political and identity around COVID and behaviors about sort of who believes in vaccination or who believes in the disease, and kind of the belief of how it should be managed, that you have people of like-minded belief who are gathering together. So the unvaccinated are not simply sprinkled through the community, but are oftentimes congregated in families and social groups, and political people, how they identify politically. And that's unfortunate that identity is having an impact, because it does, I think, complicate sort of this situation about who's getting together. And the reality is that the concept of social distancing and masking, these protections, which some people don't even view as protections, they're going away. And so the vaccine is really the main, is your main form of protection moving forward. And we've seen in Jefferson County, it was interesting when we started our vaccine campaign. At one point, we probably did 25,000 vaccines through January through May, but in the last month we've done under 1,000. So you kind of think about that, sort of about 5,000 per month average. And now that we've kind of gone to the new model, which shows this flattening of vaccine demand. And so we're continuing. We are still giving vaccine. We're still vaccinating new folks. We're still counseling, and we still do have a vaccine hesitant population. I think the barrier of I can't find a vaccine really in this community is I feel good that is unlikely the case at this point. If you wanted a vaccine at this point, you probably can get one. The question is kind of getting to that point, or getting over the hurdle, and some people really still needing just kind of questions, and having one friend saying, you should do this, and having another friend or family member say, no, you don't want to do that, and kind of feeling caught in the middle. So I'm seeing that clinically, and those are the folks that we're trying to really get the right information to and answer the questions and feel like they can feel good about it. So I think there's still that part of the population that's there. But the reality is that we're going to hit a peak here. I don't think we're too far away. That the reality will be that moving forward, we're just going to have a part of the community that's going to be susceptible, and that we will be seeing come into our emergency department or come in the walk-in clinic, and a portion of them be hospitalized, and particularly as we see these variants. And so the Delta variant, which is the one that's getting a lot of the press right now, more infectious, probably causes more severe illness. So the good news for Jefferson County, we're definitely have a much better firewall than other communities. I was looking at some of the vaccination rates across the state, and I think Franklin County looking at like under 30% vaccination. And an outbreak in a church or a workplace or a wedding or kind of big gathering with a more contagious variant, and they're a small hospital system, could look very similar as far as getting overwhelmed to what we saw 12 months ago. So Jefferson County, again, I think we will have the structure moving forward, anticipating. So some of the things that are changing, you're probably aware, and I'm sorry if I repeat anything anyone said, because I've been multitasking with some hospice work today, getting late. So I apologize if I repeat anything, but you may know that emergency management and our public health partners are starting to take over some additional responsibilities around testing. Travel testing is going to be managed through health department and in a different approach rather than or outside labs that we're not going to be providing the testing service for that. Contact tracing, people who aren't requiring particularly immediate medical attention, and contact tracing screening, that testing is going to be arranged moving forward through the health department, which will be helpful for us as far as unburdening some of our resources. And the phone hotline for general information. So certainly we anticipate that people will be calling their primary care physician. We're at a point now where if you have a primary care provider in county or out of county, they should be prepared. Those offices should be prepared to handle calls about potential COVID symptoms or COVID infection. But general information around COVID and coordinating some other questions for the general community, particularly people who don't identify as Jefferson healthcare patients. The Department of Emergency Management is going to be standing up more of that phone service and sort of taking on that role. Much in the way in the beginnings, we took on that role because the state was not going to have the capacity. Do you remember there was a COVID hotline in the very beginning with people calling into at the state level, and we kind of thought that's just not going to work for folks. They're not going to have the capacity. But we're in a place now, we're in a different place of the pandemic where emergency management, the number of calls or the types of calls, they'll be able to supplement what people who have a medical home will be able to resource. So that's just kind of a glimpse of sort of how things are looking or shaping up as we kind of move to the future. So I think as a community we'll be in good place. So it sounds like a couple questions before I move on.
I have a question. So being as there are unvaccinated and a good segment of unvaccinated people here, will in the foreseeable future, we will keep in place screening protocol at the hospital? And how long do we do that? I mean, is that like forever?
Yeah, it's a great question, and I think one of the things that we keep asking, because staff keep asking, particularly vaccinated staff and vaccinated patients, because they want to say like, some benefit, right? Like, where's I want a little bit of the reward of removing the mask, and And I think we talked kind of last time a little bit about this deconstruction and looking at some of our infection control guidelines. What can we loosen? Healthcare will always be the last place to lose things. I mean, we think about the number of our oncology patients. If we just kind of talk about that population coming through the lobby on any given day, and we're the place where a higher density of people who are immune compromised, who are more susceptible. So even when people are vaccinated, at higher risk in general. So we're going to kind of wait and see with that. At this point, there's no anticipation that we're bringing that down. I think what we're looking at is, the next kind of baby step is probably in non-clinical spaces for employees who are fully vaccinated. And if we know that we have a room with people in an office or closed setting, people in a meeting who are fully vaccinated, creating a way that that can be identified, and if all people in the room are vaccinated, that can hold a meeting without masks. But we're talking about non-clinical spaces, patients, not areas with the patients, and we'll see. We'll kind of watch, but at this point, even with our vaccination rate where it's at, I think to your point, which is if I say 70%, you say yay, but if I say 30% not, it has a little bit of a that's not an insignificant number. Now, some of that too are people who aren't eligible for the vaccine. So when you include the pediatric population, but still, we still have a fair number of adults who are going to be susceptible to infection, and so we do have to be mindful of that, and some level of screening really is going to be needed. Particularly, even if something went away, I'd have a hard time believing that we won't have something moving into the winter, because as I've mentioned to you all before, I think flu will be back this fall, and that's gonna I think kind of give us pause too. Mari, I think you had
Yes, I was wondering, as we look to getting into fall, hopefully several months away with the weather and everything else, what are you hearing about the need for booster shots? How long? Is there much research to show how long, or at least projected how long the vaccine lasts? Will we need annual boosters? What are you hearing?
Yeah, so far, what we're hearing is confidence so far that don't need a booster yet. But I think with the, when people are seeing the variants and they're seeing some, depending on the vaccine, maybe not a strong performance, I think the writing's on the wall that probably there's going to be a role for it. It's now we're starting to look out. You got to start also thinking about production, and you got to start thinking about also outside the U.S. right? So production for boosters in the U.S. may take away from production of primary dose vaccine on a global scale, and I think we now need to begin to kind of think about the importance. Well, if you haven't already been thinking about it, you should be. Everyone should have been thinking about this to begin with, which is the global vaccination effort, and the importance of making sure that this isn't just we got within our national borders, so we're good to go. And so I think probably if a booster dose is needed because there's evidence of waning immunity, then that's going to be important. But I think folks also have to balance that versus if it looks like the initial immunity from the first round of doses is pretty good, that we're gonna probably try and kind of wait on that booster dose until we really feel like it's needed. So the initial studies that have come out about length of immunity so far have been reassuring. But we may get into a place where if there's a variant where you see a drop off, particularly a drop off from particularly the Pfizer and the Moderna vaccinations, we may be compelled to have to look at some booster doses. And then there's all different kind of ideas too about mixing and matching. And so more to come, but I don't think there's anything definitive yet. Now, I just got back from vacation. I was trying to not read about COVID as much. So if you read something in the last 7 days that I didn't, feel free to correct me. But that's kind of the sense of where things are going.
Now, the only thing that concerns me, to the extent of worldwide, some countries haven't even started vaccinating.
Yeah, and I think the other problem is, if you might have seen that some of the countries that were feeling pretty good about their vaccination efforts, but the couple of the vaccines that were produced from the Chinese manufacturers are showing lower efficacy in real life, and so a couple of countries that had really good vaccination efforts, but are seeing outbreaks currently because they're not, they're kind of seeing more like in the 40% effectiveness. And so, so yeah, the getting, initial vaccines, getting the right vaccines. And again, I think that, that requires resources and energy. And then if you start trying to kind of put in additional boosters, for second doses here, when you've got other places that, as we're opening up our borders and people are now starting to travel out of the country, and then we're going to see kind of more things open up, kind of people coming in. So it is important that that this is a global effort.
Thank you.
And, yeah, Case. Oh, I think you're on mute still.
Great report, and I hope you didn't read anything about COVID during your 7 days away. And just to say that Tom Locke, in his reports to the Board of Health last week and to the commissioners the beginning of this week, echoed some of what you're saying in terms of the probable need for boosters. We're going to be dealing with vaccination of coronavirus variants for years to come. But he also mentioned the Brazilian variant, which I guess it's now called the Gamma variant, which is really raising its head up in British Columbia. And so any vaccine boosters that come along may well be tweaked so that they're even more effective against some of these emerging variants.
Yeah, agree. The really nice thing with the technology, particularly with the mRNA vaccines, that there is a path to manufacturing a new vaccine, or kind of tweaking the current vaccine to do that in a way. It's one of the really great things about this technology, which is that the way that you can kind of redesign the vaccine kind of pretty quickly. So there's opportunity, but it's all about resource, and we, as we've seen with kind of what happened in Baltimore with the one plant that got a lot of money and then had to throw out a bunch of vaccine. The vaccine is only as good as what you can produce and put in bottles and do it in a high quality, safe way. So so the effort isn't over. I know people are kind of very excited, and we've probably all started to see more people as we've gotten vaccinated and do a little bit more, but the global fight is really I don't even think we're in the midway point on the global fight. So.
And I wish that we would release the information as to how to produce those vaccines,
right.
rather than have them be proprietary to pharmaceutical companies who develop them with taxpayer money.
There you go. Well, if any other questions on COVID, and I'll finish up a couple other items I just want to kind of follow up on, if that's okay. Behavioral health. Last time, I know you were wondering about some updated statistics around behavioral health, and particularly around medically assisted treatment. So I came back with a few numbers, and just to give you a little snapshot of where some of our services, as far as utilization and what we're kind of seeing with regard to frequency and volumes with individuals seeking care for behavioral health. Currently, the number of folks who are actively engaged in medically assisted treatment is about 36 to 40. That number again fluctuates a little bit because people kind of go off the radar, and then we get new people on. But at any time right now, the team is typically managing kind of somewhere in that ballpark number of 36 to 40. On the behavioral health side, just kind of just confirming what you probably suspected, which was that we were seeing more behavioral health visits in the primary care clinics for the last year compared to we have a dashboard where we can compare the previous 4-year average, and 30 to 40 more visits a month. And if you think about sort of visits at times being down for other types of things in a month, so overall percentage of visits actually going up, and very similar in the emergency room for adolescents. So as we saw, if you looked at overall behavioral health visits in the emergency department, it would look fairly consistent, like that had not changed much. But when you put that in context, that over COVID, that actually our overall ED visitation actually was down for such a long period and is just starting to come back, that the overall percentage of visits that we were doing, what we were seeing in the emergency room, we were seeing actually higher acuity people, and we were seeing more mental health, the behavioral health care in that setting. And particularly, that was particularly true, mostly true for adolescents. Actually, there was some reduction in adult behavioral health visits, which I thought was kind of interesting in the emergency department. As we saw the adolescent and pediatric behavioral health visits go up, we also saw length of stay in the emergency department for those patients go up, which reflected the reality of what we were seeing across the state, that adolescents who needed placement for behavioral health needs for inpatient, more acute services, there was not capacity. And so we had individuals that we had to keep safe in the emergency department. We don't have a pediatric service upstairs on the floor anymore to provide them. So, again, kudos to the emergency department who was working with Discovery Behavioral Health to provide at least some services and begin the beginnings of case management with adolescents while they're in the emergency department. In May and June, it looks like the initial numbers have seen a little bit of a trend down. We're going to need to see another couple months to see if that's happening. So hopefully, combination of getting through the school year combined with a little light at the end of the tunnel and some things opening up, I'm hoping we're seeing a reflection in those numbers, but we'll have to give it a little bit more time to see. But I think that the take home, what you'll see published, and I think our experience will be the same, which was that overall behavioral health utilization, the need for it or the use of it all increased. So we're in a good place now. We're our program, the AIMS program that we use, our MAT Navigator, our psychiatric nurse practitioner who's pediatric adolescent trained, those pieces are in place. And so as we move through the summer and into the fall, we should be positioned to continue to play the role that we've been playing so far. Couple other things I just wanted to mention. Next month, from a palliative care and hospice, we're anticipating accreditation body coming in, which is kind of exciting. It's exciting because part of that accreditation is for our palliative care program, which we've been doing a slow rollout of. So Renee Yamane, our palliative care nurse practitioner, is doing a great job. She's keeping a small panel of patients until we go through the accreditation process. Then we'll look to kind of expand the role, but the teams work. One of the things that with Renee's addition, we've been able to do previously, I think I mentioned that we were able to expand palliative care services for our home health patients to provide a little bit of a bridge between people who are not yet hospice eligible or ready. With Renee's involvement, Renee's actually seeing people who might not qualify for home health or hospice, but still have a palliative care need. So that's the idea of having a kind of an individual palliative care program, which is that you don't need to, meet criteria for one of those two programs to still get palliative care involved. And so we're kind of excited to get through the accreditation process and then do a little bit more kind of hollering and promoting of the palliative care program and start to build up the capacity. So I think that's pretty exciting. And then as we're starting to do other, get other projects kind of back going again, I've mentioned various work. I think one interesting thing that I just wanted to make you all aware of is POCUS, or point of care ultrasound. Some of you may be familiar, or you might have had the experience with that. Some of our practitioners, particularly in the emergency department, have begun to make more and more use of portable ultrasound as almost an extension of the physical exam. The technology has really changed over the last 5 years in particular, that makes these devices portable, and technology to help with imaging and reading. This is not designed to take the place of a full ultrasound that's done in the radiology suite. This is meant to help the at the bedside practitioner, whether it's the primary care physician, the hospitalist, the emergency room doctor, the surgeon, get some very focused information using a piece of technology similar to, instead of the stethoscope, they're reaching for this piece of technology. So we decided a couple of years ago that we see where this is going, where more people who are coming out of residency are trained in point of care ultrasound, and more people who've been practicing for a while are interested in learning the skill if they haven't. So we have a couple of physician champions, Dr. Chance Irick in the emergency department, Dr. Steve Erickson in primary care, who have kind of led the way and have started a POCUS teaching workshop group that gets together to scan and learn. And we have a path from the credentialing standpoint, which I know Mari is always interested, to basically get the experience that you need. And we have a quality review program so that people can learn and then get credentialed to perform point of care ultrasound on their own in the clinic. So we've made some capital investment. We have some different point of care ultrasound devices that are headed our way, will be present in inpatient and outpatient settings. And so I think just one thing that's good for you all to be aware of, you're going to be, you may, if you're, in the grocery store and you run into someone, they may say like, hey, last time I was, seeing my primary care doctor and I, had this symptom, they whipped out this ultrasound out of their pocket and attached it to their iPhone, and it's about, really. It's not, again, it's not meant to take the place. It's not meant to be the full diagnostic ultrasound that's done in the radiology department. That's, this is typically to answer a particular clinical question and provide an image and another piece of data to help guide your decision making. But it's a useful tool and can really help guide patients in the right direction. And there's a growing body of research to show the benefit of these point of care ultrasound examinations. So, and I think it's great for the experience for the patient, because it's very engaging with the patients who get it done, because they can kind of see the image and you can educate about the anatomy. And so I just think I'm really happy about the fact that this is not just sort of one person kind of doing it on the side. That one of the things is, we said, if we're going to do this, we want to do it the right way with a quality review and credentialing and all. So, but that project's taking momentum, and I think we've got quite a number of providers. Obviously, the orthopedic doctors are more interested in using it for musculoskeletal. Hospitalists have their things that they find it more beneficial for, and so everyone can kind of find sort of where they find it useful in their practice. But it's something we're going to see more of, and I think it's going to be a great addition to the experience for the patients. And I'll stop there and let you guys ask any more questions.
Any questions for Dr. Matter?
I'd just like to comment, as a third youngest member of this board, when I started my nursing training, we didn't have ultrasound. It was not yet invented.
Okay.
Yeah, I have a quick question. Is that a reimbursable procedure? And is that, well, I don't, that wouldn't be the only reason to do the credentialing. It's for safety and quality care stuff, but is that reimbursable?
Yeah, there can be. Yeah, I think that's part of the kind of exploration. It's not the intent is to train people more for, to your point, which is the kind of the quality and
Sure.
feeling good about it. But yeah, some of the exams are not to the degree of the kind of what the radiology exam, but sometimes what they can do is they can be cost saving in the standpoint of they can feel reassurance that maybe they don't need a bigger imaging study and that maybe I'm
Mhm.
going to take the diagnosis in a different direction that doesn't require kind of
Mhm.
a more intensive study. So it could be kind of more cost saving actually in the upfront. And maybe pick the better, if there is an imaging study, pick the better one with a little bit another piece of information. So but yeah, there is definite, and then I think kind of depending on the payer, with our Medicare encounter rate, I don't think that there's, I have to kind of see, but that's unlikely that it's going to be a kind of part of those, but certain other payers may have additional breakout for those charges. That's probably a good Tyler question. So,
Okay.
Would they, this may be premature, but maybe you haven't planned this much yet, but will every physician have one, or will there be one in every clinic, or how
yeah,
will
we're
that
gonna we're gonna see the uptake. So I think I can't remember how many units we have. So we're trying to get a little distribution, but there'll be a hospital or clinic owned kind of loaners and sort of at a station, and then providers can decide if they want to purchase their own at some point and treat it like almost like your own stethoscope, right? And have it so as your piece of technology. What's important for folks just to know from a security, so when we're capturing these images, which patients may be like, well, what's going on there? They kind of plug into the phone. But much like how we use our phones, we use our phone cameras to capture images that go into Epic. There's a conduit and levels of HIPAA security that meet all the healthcare IT requirements so that there's not saved images on people's phones or any health information or anything like that. So the phone is kind of the conduit to secured databases, but so it's a secured experience for the patient, and like I said, it provides an extra data point to make better decisions.
Excellent, thank you. That's exciting.
Yeah.
Any other
Great.
questions? Thank you, Dr. Mattern. Thank you for a great
Thanks.
presentation. So, all right, well, then we will move on to our board business. Do we have a report from you, Case, for the Board of Health report?
Yes, but what I'd love to do first is ask Mike one question. The transition to Dr. Mattern was so rapid that I didn't have a chance to ask a question about the health advocacy meeting that you had. Apparently, you and the staff are following things pretty closely, both in Olympia and Washington, D.C. And I wondered whether, if they are sort of our advocacy reps on the board, whether they ever have access to those meetings, just to keep them informed.
Yeah, not at this point, not up to this point.
Uh-huh.
It's mostly just been staff level, but particularly as we ramp into sort of the advocacy season, that's not a bad idea.
Okay, thank you. Then in terms of my report, first of all, I'd like to make a few comments about the work that we're doing with the Institute for Healthcare Improvement. There was another meeting with the members of our cohort. I think it was either last week or the week before. And these are attended by a number of people on our Health Equity Committee at Jefferson Healthcare. And I think they continue to be very valuable meetings. And I just want to commend our staff for making a dedicated commitment to that. At this last meeting, there was considerable discussion about how do we communicate about racism, and they shared a sort of what's something that they call ACT, ACT, which are sort of the steps in how they recommend you talk about racism with people. And the ACT stands for Affirm, Counter, and Transform. The affirm is you start speaking from the heart and you explain why we are all in this together and what the whole issue of dealing with racism means to us personally, and trying to reach some common ground with people. The counter is explain why we have a problem, and to basically not be afraid to take on the discussion about race directly. And the third is transform. It's to reframe the whole issue of winners and losers with regards to working towards health equity and eliminating racism, and really end with heart and a solution that hopefully will help us all as individuals and as a community deal with the issue of racism, and how important it is for us to continue to deal with it head on. And then with regards to the Board of Health, there was a meeting and I sent to the commissioners the packet, the rather lengthy packet, and also a very brief summary with regards to COVID-19 and the pandemic. A key takeaway is that even as things are changing, both with a new masking directive that Dr. Locke issued on the 7th of June, and of course the changes that we expect any day now from the governor with regards to the easing of restrictions. The bottom line is that we should all continue to recommend that although vaccinated people will essentially have a lot more freedom, that those who are not vaccinated should continue to wear their masks indoors when they're in public places, for some of the reasons that Dr. Mattern explained. Once again, Dr. Locke credited the leadership that Jefferson Healthcare has taken on this initiative during the last 15 months as a big reason for why this county has continued to be a leader, both in controlling the number of people who have received COVID, who have been afflicted with COVID-19, as well as treating them, and particularly in terms of our immunization rates, since we have given the vast majority of vaccines through our public hospital district system. And then just a quick note that the public health received monies to be able to provide a $35 a month farmers market check to those people, to those families on the WIC program. And this has obviously been a great boost to everyone to improve the nutrition here and for the people in Jefferson County. And then finally, that the Quilcene High School now has a teen clinic up and running. They've had that for several months, but the provider, Dr. Melinda Bowers, will also be there every Thursday afternoon during the summer to continue to provide important teen services. And again, this piggybacks onto what Dr. Mattern was saying, how the importance of providing mental health services and some kind of support to teens during this very difficult time, particularly in the more outlying rural areas of this already rural county. So I just want to say that our public health department in this county, we're blessed with a great team of folks, and obviously an excellent public health officer. Vicki Kirkpatrick, who has been the director there, is retiring, and I believe we're on the lookout for a replacement. And so we'll stay tuned for that. And she, by the way, has done an outstanding job advocating, both running programs here and advocating in Olympia for foundational public health services, which are routinely underfunded all across this country, and which will be addressed a little bit in some of the new legislation that's restructuring public health in this state, as well as beginning to provide perhaps 10% of the additional funds that are needed to provide all of the foundational services, but it's a start.
Okay.
And I see that Matt has his hand up.
Yes.
I'm not sure if that's for me or for you.
Well, are you finished with your report?
Yes, I am.
Okay, great. Matt, do you have a question for Case, or do you have something for the board? Matt? Okay. Thank you, Case. Okay, great. Yeah, that's it. Probably it is time, I guess, to take another look at that and where we are and what's been happening. So, Mike, have you got any inspiration or insight into that?
No, there's still a tremendous amount of Jefferson Healthcare support for CHIP. Alyssa actually is supporting several committee meetings, and there's a lot of activity going on there. I know that John and Public Health are having similar discussions and talking about transition. But I think at some point it probably makes sense to, if the board wishes to continue to have those meetings, to start them.
I might say I've been to several of the CHIP groups, both the youth and the elder, the group for the elders, and there is an effort, a real push to get things to the point where we can get another report prepared for the boards this fall. So I know that that's an effort that's on track, I believe.
That sounds good. We can work towards that then. Maybe Mike, can you look into that for us and get us, find out where we stand and whether or not that's doable?
To set up a meeting?
Yeah, for a joint meeting, if there's enough that's going on, if we're at that point. I don't know.
Well, John and Lori are in discussions about that, and so
yeah,
I think
how about if we follow their lead, because it's also the county and the city.
Yeah.
So I think maybe John and Lori should be the driver to that.
Maybe we could get a brief update from John at the next board meeting.
Sure.
Sort of where things are.
All right.
Maybe we do that as part of our beginning discussion for the beginning of our meeting, a 15-minute update or so, 30-minute update from 2 to 2:30. We could talk to John and see if he'd be able to do that.
Sure.
So, okay, great.
Hey, Jill, I assumed that we would be done by 5:30, and I have a meeting right now. So if there are no other questions for me from the board? I need to zip. All right, good to go?
Okay,
Okay.
I just have
Thank you.
one.
Thank you
Thank
very
you very
much. Bye-bye.
I just wanted, wait, hold on. I just wanted to say one thing. Mike, I just wanted to thank you for your leadership in the amazing work that Brandy presented during her segment. So I think he boogied out beforehand, but maybe he'll listen to the tape and the
There you
record.
go. In his free
As if he
time,
doesn't
right?
hear it, as if he doesn't hear enough from us. Yeah, thank you.
Uh,
Okay, so is there any other board business? Mari or Bruce, do you have any, or do either one of you, Matt or Case, have
I
any?
just make a motion.
Oh, well,
if
if I could just make one comment.
come on, Case, you're so
Oh, come
verbose
on.
today.
I
Come
know,
on.
I know, I'm terrible. I am going to be in Wisconsin at the time of the July board meeting. I can try to patch in. I can certainly try to patch in by phone if there's a in-person meeting, and I can try to Zoom if there isn't an in-person meeting. So I'll do what I can.
Have a great trip, Case.
Thanks.
That's good. All right, we have our meeting evaluation. So Bruce.
Yeah, I mean, as always, it's great information. And, you know, a lot of people talk about this past year with COVID kind of being a lost year and all the bad things. But, you know, when you listen to Brandy's report and Mike's report and Joe's report, there's just a huge amount of good things that have happened, either, you know, because of COVID, but also, you know, in spite of COVID going on. I mean, there's just been a lot accomplished.
Well said. Case?
Amen. Nothing else to add. Just a great meeting. What a great organization. The spirit that everybody brought to this last challenging year just really shines through. And I feel privileged to be able to serve on the board.
Matt? All right, I think some of them have heard back. I haven't answered to all of them because I haven't seen some of them, but apparently, but you may be getting more than I'm getting. I don't know. At any rate, that will be taken care of as soon as the governor allows us to meet again, which hopefully will be in a few days. So next month we should be able to have public participation again. That will be good. Mari?
Well, as Bruce had said, and Case and yourself, and excellent meeting, very good information. I mean, a huge amount of information, but also to reiterate the quality of the leadership, the SLG, Mike, all his team, but also the grassroots, the people on the ground who have made all this possible. And you know, Matt has been on the ground floor like I have, and it takes a lot of hard work and dedication. I think it's testament to those staff just how well COVID has been managed to the best of the ability, and also all the other things that have been going on. So I think hats off to everybody in the organization. Terrific. Jefferson Healthcare teamwork does make the dream work.
Oh, that's good. And I totally agree with you and what you said. It's just obvious there is there would be no Jefferson Healthcare if it weren't for its people.
Yeah.
Its team, it just wouldn't exist and be as good as it is. So thank
Jill,
you.
if I could make one more comment to follow up on Matt's comment, that when there's an email that comes to all of the commissioners, that you will respond for us.
Yes.
Even if it's just to say we acknowledge your letter and then whatever else you want to say, just so they know that we have seen it and read it.
Yes, I have done
Great.
that most of the time. Like I say, in the last, I haven't had internet access for 2 days now. I got it back today, so I don't know what might be in the mailbox now, but
Yeah.
certainly respond if there are some.
Okay, and if you could just copy us on that, then we'll
I'm not
know.
sure that I can do that. I'm not sure that it doesn't make a serial meeting. So let me find out from John what he says about that, and whether or not.
I think you can always CC us and just period. I mean, that's. But why don't you find out from John?
I will, and that's certainly appropriate.